Hello, and welcome to an episode of Ultrasound Tips and Tricks. I'm Dave Bosch. Today, I wanted to start a 3 or 4-part series on regional anesthesia to get people into a little bit in the background of anesthesia that we can provide for our emergency patients. So, I'm not going to talk about anything specific today as far as the blocks, but the mindset and the medications that we use so that you're ready to go when you start doing these. I want to start out by talking about the ways that I think about doing these blocks. We're going to talk about getting the right patient, doing the right block, selecting the right medications, and having an appropriate dispo plan for these patients. So the first thing is, absolutely, you want to set yourself up for success. This goes for any procedure, but especially when you're doing a new procedure, you want to have everything set up so that you will be successful the first time. And so that really goes down to the patient. We want to select the patients that this is going to help the most for, and try to avoid patients where you're going to struggle. In my experience, there are several patients that become struggle buses, namely obese patients. It's just difficult to do ultrasound guided anything on, and so I try to avoid it unless absolutely necessary. I would also recommend trying to avoid patients with chronic pain. They are typically challenging to get anesthetized to a degree where they are comfortable, regardless of what you're doing. And I put an asterisk here because these are often the type of patients who we really want to try to do a nerve block on, because they're so heavily medicated that doing a procedural sedation seems riskier than normal, and so you're trying to do something beneficial for them. But in my experience, this is fraught with problems, and I'm doing it less and less in this patient population. The last group of patients that I would avoid doing this on is the truly hysterical person who has some injury and they can't bring it down. These patients, we all know them, and maybe it'll take just a little bit of fentanyl, a little Versed to get them into a better mind space so that you can do a regional nerve block. But trying to do a nerve block on somebody who is hyperventilating and about to pass out is not going to be easy, and you're going to fight them the whole time, probably be unsuccessful and end up sedating them anyways. So I would definitely recommend avoiding this group of patients. When I'm setting up for a nerve block, talking through it with patients, I do like going through the possible complications. I wanted to bring this up so that people that have never maybe had this conversation with patients know kind of what I'm doing, because I do a lot of these. When I talk to people about is I tell them that it's possible that we could go through this whole nerve block and it could fail, and that it could give them incomplete anesthesia and we'd have to do something additionally. I tell them that there's a low risk of damage to their nerves when I'm actually doing a nerve block, and that risk is somewhere around 1% of causing some kind of longer-term numbness. Usually it's from bruising around the nerve, which resolves. And then I go through the options, depending on the injury. If it's an orthopedic upper extremity injury, I might tell them that I've got options of a full sedation, which comes with risk X, Y, and Z. We could do hematoma type block with pain management, which leads to X, Y, and Z complications or X amount of pain, or a nerve block, which typically gives great anesthesia, but could cause or come up with these other complications. And so that those patients, they have all of the information available so they can make a decision. And then a lot of times I'll recommend one over the other depending on the above things that we talked about, so that we are all in agreement of what the right procedure is to do. Getting into the actual block, you really want to set this up in a way, again, that's going to be successful. You want to proceed with using the right anesthetic just for what you need and nothing more. When I'm doing this, I'm looking at, well, how long do I need somebody numbed up for? What's my goal? Is it immediate pain relief for a painful procedure, or is it pain control where I'm sending somebody home for a day? And so the way I think about this is lidocaine for short, painful procedures where I want it to wear off and to discharge the patient home essentially fully neurovascularly intact or neurologically intact. Bupivacaine for smaller volume blocks where I'm not worried about doing a lot of anesthetic administration because of the toxicity associated with bupivacaine. And then I use ropivacaine for large volume blocks, fascia iliaca blocks, serratus blocks, something where I'm putting in large, like kind of max volume doses, because the safety profile for ropivacaine is so much better than bupivacaine. I don't routinely use epinephrine in any of these combinations because, one, I really want the anesthetic to diffuse around the nerve, and if you use epinephrine, sometimes it doesn't spread out as much. And then also, I'm not really sure if it does anything to the nerve or to the vasculature around it, but it's just simpler when you're not using an additional medication. I also don't waste time mixing bupivacaine, lidocaine. Recently, a study has come out that says really there's no difference in that time to onset. I think we've all been taught at one point that if you use a mixture, that miraculously they'll have like immediate pain relief, whereas if you don't, they're going to suffer for hours on end before the bupivacaine kicks in. I think we've all seen clinically using bupivacaine, you get fairly rapid onset of pain control. So my recommendation, choose one medication, don't have your nurses, or you mix it and just go from there. And then lastly, as you're setting these things up, get all the equipment that you need in the room the first time. The nerve block kits are great. We're trying to roll these out at more and more facilities so that you don't have to go searching for everything. But grab everything you need, have it in the room, and if you need something extra, try to have somebody go run and get it so you can stay in the room and continue to focus on the patient. I do want to spend a little bit of time talking about the drugs. This is very important. I think we've all been through basic pharmacology on these, but the doses, they start to fade if you don't use these a lot. So I want to go through them. I've got them listed from top to bottom in order of toxicity, or from least to most. And so from lidocaine to ropivacaine to bupivacaine, it becomes more and more toxic. And then also, if you look at the dose, you can use more lidocaine, less ropivacaine, and the least bupivacaine. So that's actually how I remember these doses. So 2 bupivacaine, 3 ropivacaine, 4 lidocaine is because they're reverse in their toxicity. So, and for a 50 kilo patient, I have on this chart written out the recommended doses to use. Obviously, you can use more for a heavier patient, but you don't want to use obviously more in somebody under 50 kilos. And this is pretty rare that you've got somebody under 50 kilos you're doing these blocks on, especially in adults. The durations, I don't want to get emails that lidocaine lasts 2.8 hours or bupivacaine lasts 12 hours. These are general guidelines on what these medications, how they last. And so they're in general that much time. This is what I tell patients too. The other tip I have for doing blocks is that if you're going to do a fascial plane block where you need to do a large volume, like a hip block, like a fascia, like a block, take the max dose that you can give that person. So for instance, ropivacaine, 0.5% at 30 mils. And I take that and I'll put that into a 60 mil syringe with 30 mils of saline, and essentially making a 0.25% solution, but 60 mils. You can have such more confidence injecting that into the fascia iliaca, because if your needle's not right half the time, you've got twice as much anesthetic to soak in there, and you'll be successful more often. The patients won't notice the difference. The anesthetic will last the same amount of time, but you will be more successful. And so that's definitely a tip. You may need an assistant to hold the extra large 60 cc syringe with the adapter needle, but it's well worth your time. The last thing I want to talk about is discharging patients. I think it just takes a couple seconds to think about sending somebody home after doing regional anesthesia, what might occur. For instance, doing a large upper extremity block for a distal radius fracture may be great, but sending that person home at 1 a.m. to go right to sleep with an arm that's fully anesthetized may not be great when they roll over on that arm and lay on it for 2 hours and then come back with a Saturday night palsy on you. So you will probably find yourself in peer review if you do something like that. So think about how long that block is going to last, what type of block you did. You wouldn't keep somebody in the ER for hours on end for a digital block. And so depending on what you're doing and what their neuro status is after the block, just think about sending them home with maybe a sling or somebody to watch them and make sure they can't roll onto it or damage their extremity until the nerve regains normal sensation. And lastly, I wanted to talk about anticipation of post-block pain medications. I think you just have to take a second and think about what type of pain is expected when that nerve block wears off, and treat appropriately as you would. That's it for this session. Next time we'll talk about an actual nerve block. We're going to go through several different types, and I'll try to break it up so that these sessions can remain somewhat short. Thanks for watching.